Hello, good morning everybody. We speak today about ovarian hyperstimulation syndrome. What we mean by ovarian hyperstimulation syndrome? متلازمة تحفز المبيض المفرط is a combination of ovarian enlargement due to multiple ovarian cysts and acute fluid shift out of intravascular space. Ovarian cysts result from multifollicular development. As we know, spontaneous ovulatory cycle is interaction between hypothalamic pituitary ovarian feeded back limit follicle recruitment to small number of early enteral follicle. Full development restricted to single leading follicle in response to LH search. In normal ovulatory cycle, little number of early enteral follicle وبس واحدة منهن شو تصير؟ تكبر وتصير as a leading follicle in response to LH search. In cases of ovarian hyperstimulation syndrome due to ovulation induction involve administration of gonadotrophin overriding normal feedback mechanism. مو حكينا قلنا normal ovulatory cycle hypothalamic pituitary ovarian axis, a small number of enteral follicle. Only one leading follicle become big size, mature Ovarian follicle in response to LH circ. With administration of gonadotrophin, this normal feedback overriding. This result in recruitment of large number of enteral follicle. Several of these are sustained as a leading follicle, capable of either luteinization or ovulation. يعني هواية راح يصيرن enteral follicle وقسم منهم ممكن 2 ممكن 3 ممكن 4 ممكن حتى 5 شي يصيرون leading follicle luteinize or ovulation. The etiology of ovarian hyperstimulation syndrome: exogenous gonadotrophin luteinization of large number of enteral follicle following administration of SCG and rarely with the clomiphene citrate. يعني شنو؟ المريضة من تجيني متلازمة تحفز المبيض المفرط لازم أسألها شنو ماخذة أدوية منشطة للحمل مثل من gonadotrophin أوبر تحت الجلد اللي هي FSH or human menopausal gonadotrophin or rarely with clomiphene citrate. Endogenous LH sears, mild ovarian hyperstimulation syndrome in spontaneous multifollicular development. يعني مرات normal menstrual cycle without ovulation induction lead to multifollicular development. But in this case, mild ovarian hyperstimulation syndrome. ممكن المريضة تجيك ovarian hyperstimulation syndrome يعني multifollicular development, multiple ovarian cyst with a shift of fluid from intravascular space to third space loss. تقول أنا ما ماخذ أي أدوية منشطة للحمل in cases of spontaneous multifollicular development. FSH receptor mutation, severe recurrent spontaneous ovarian hyperstimulation syndrome during pregnancy. ممكن المريضة حامل وتجي severe ovarian hyperstimulation syndrome due to what? FSH receptor mutation, thereby allowing stimulation by endogenous HCG and persistent stimulation of FSH during pregnancy, resulting in excessive follicular recruitment and subsequent ovarian hyperstimulation. Pathogenesis. The pathogenesis of ovarian hyperstimulation syndrome, development of ascites, hypovolemia due to capillary permeability are the cardinal clinical element. Hypovolemia results in hemoconcentrition, decreased CVP, low blood pressure, and tachycardia. بالتعريف قلنا ovarian hyperstimulation syndrome is multiple follicular cysts lead to ovarian enlargement with shift of fluid out the intravascular space. حكينا قلنا الأوفرين سيستم من تجي gonadotrophin ovulation induction lead multiple enteral follicle and number of these follicles become the leading follicle until luteinize. What the cause, what the pathogenesis of shift of the fluid from intravascular space to third space? Role of vasculoendothelial growth factor. Ovarian hyperstimulation syndrome appear to be due to increased capillary permeability, triggered by excessive release of one or more vasoactive substance secreting during maturation and luteinization of multiple follicles. Okay? Vascular endothelial growth factor of follicular origin is the main increase vascular permeability and new vascularization. يعني قلنا ننطق gonadal trophin صار multiple antral follicle, multiple leading follicle, so multiple ovarian cyst and ovarian enlargement. Shift of a fluid out the intravascular space due to vascular endothelial growth factor of ovarian origin. That this is a more vasoactive substance secreting during maturation and luteinization of multiple follicles, increased vascular permeability and new vascularization. Other risk factor for increased vascular permeability: interleukin, renin, angiotensin cascade, kinin, kallikrein system, and selectin. Renal effect: severe hypovolemia is associated with decreased renal perfusion and increased reabsorption of sodium and water in proximal tubule, lead to oliguria and low urinary sodium excretion. Exchange of hydrogen, potassium for sodium in distal tubule is reduced. Result in accumulation of hydrogen and potassium ion, causing hyperkalemia and tendency to acidosis. So renal effect: hypovolemia, decrease renal perfusion. ايش تجي المريضة؟ تجي oliguria. تجينا oliguria. Classification: we have 3 grades for ovarian hyperstimulation syndrome: grade 1, grade 2, and grade 3. Grade 1, mild hyperstimulation, is characterized by ovarian enlargement with multiple follicular and corpus luteal cysts measuring up to 5 by 5 cm. Lab finding: serum estrogen more than 1,500 picogram per ml. Progesterone concentration more than 30 nanogram per ml. Everybody know each mature Gravian follicle give 150 picogram estrogen. In cases of ovarian hyperstimulation, we speak now about grade 1 or mild hyperstimulation. Multiple follicular or corpus luteal cyst مو أكثر من 5 سنتيم، والاستروجين مو أكثر من 1500، والسيروم بروجسترون أكثر من 30 نانوغرام بير. Grade 2 or moderate hyperstimulation, ovaries enlarge 12 by 12 cm. Symptom: nausea, vomiting, and diarrhea. Sudden increase in weight of more than 3 kg may be early sign of moderate hyperstimulation. يعني ممكن mild or grade 1 ovarian hyperstimulation, little bit lower abdominal discomfort. Ultrasound was done, we found multiple ovarian cyst or multifollicular development not more than 5 cm by 5. In cases of moderate hyperstimulation المريضة تيجي شنو؟ عندها ساين وسيمتوم. شو تقول؟ بطني نفخت، عندي ألم ببطني، أحس مختنقة قليل لأن كبرت البطن، كبرت الأوفريز، وعندها شنو؟ nausea, vomiting and diarrhea. sudden increase in weight. إذا هي متابعة وزنها تقول زاد وزني أكثر من 3 كيلوات من أنا أخذت المنشطات. Grade 3 or severe hyperstimulation, a presence of large ovarian cysts more than 12 by 12 cm, ascites, pleural fusion, pericardial fusion, electrolyte imbalance, hyponatremia, hyperkalemia, hypovolemia, shock or marked hemoconcentration, increased blood viscosity, thromboembolism, and even DIC in cases of severe ovarian hyperstimulation syndrome. So it's a serious condition if become severe ovarian hyperstimulation. Risk factor يعني شنو هم؟ كلهم infertile ويجون for ovulation induction. ليش ننطي ovulation induction؟ إذا المريضة إجت infertility and wish to conceive. The risk factor مو كل المرضى يصيرون ovarian hyperstimulation. So إحنا gynecologist دائما ننطي ovulation induction. In case young age, low body mass index، الضعاف دائما يخوفون، polycystic ovary syndrome، history of ovarian hyperstimulation. anti-Mullerian hormone more than 3.3 enteral follicle count. يعني إذا أشوفها هي تجيني day 2 of menstrual cycle, if I see the enteral follicle count more than 3 to 4, so there is a risk factor for ovarian hyperstimulation syndrome. We have primary prevention. يعني مو كل مريضة تجيني تريد تحبل أسوي عندها pericardial fusion أو أسوي عندها pleural fusion, ascites, multiple ovarian cysts. No. So we have primary prevention. I want to do what? Controlled ovarian stimulation, مو ovarian hyperstimulation. Controlled ovarian stimulation. So minimal gonadotropin dose step up regime. يعني شنو تجيني أول سايكل أشوف شنو ممكن أنطيها بس 2 gonadotropin يوم 7 ويوم 9 من السايكل أو يوم 3 ويوم 5 من السايكل and see day 11 المريضة شو أسوي لها transvaginal ultrasound to assess the number of mature follicle and send for serum estrogen. قلنا كل وحدة mature follicle تنطيني 150 بيكوغرام استروجين. إذا أشوف ثلاثة فوليكل باي ترانسفيرجينال التراساوند أشوف السيرم استروجين مثل 450 معناها 3، أشوف ممكن 500، أشوف ممكن 600. So I want to do primary prevention. Metformin, I can give metformin little bit decrease ovarian hyperstimulation. aromatase inhibitor يعني ما أنطي كلومفين ستريت، إيش أنطي لتريزول. IVF ممكن أسوي IVF individualization laparoscopic ovarian drilling. This is a primary prevention. Spontaneous regression occur 10 to 14 days but may take longer if implantation occur. The incidence of spontaneous regression in grade 2 ovarian hyperstimulation syndrome 3.1 to 6%, in grade 3.25 to 1.8%. So spontaneous regression حتى لو اجتني المريضة ovarian hyperstimulation syndrome ممكن spontaneous regression من 10 إلى 14 يوم يعني بالليوتيال phase occur. grade 1 أغلبهم يصيرون شنو regressed. grade 2 there's little percent of regression, and grade 3 or severe hyperstimulation 0.25 to 1.8% regress. unless pregnancy occur. إذا صار البريجننسي شنو راح يصير؟ هو HCG. إذا صار البريجننسي راح يصير more persistent ovarian hyperstimulation syndrome. pregnancy outcome grade 1 super ovulation or controlled ovarian hyperstimulation, increase pregnancy rate, multiple pregnancy, spontaneous abortion, perinatal complication, severe hyperstimulation, worsen pregnancy outcome. يعني الفيت مال البريجننسي ممكن يصير multiple pregnancy, spontaneous abortion, perinatal complication, severe hyperstimulation, and worsen the pregnancy outcome. Treatment according to the grade. Best treatment is primary prevention. Secondary prevention. Best treatment primary prevention يعني أمنع حصول ovarian hyperstimulation. And if develop ovarian hyperstimulation, so secondary prevention withholding SCG. يعني المريضة انطيتها ovulation induction, clomiphene citrate, gonadotropin, development of multiple follicular cyst and serum estrogen increase more than usual. يعني ما إذا عندي فوليكل واحدة 150، إذا عندي 2 فوليكل 300. أنا هسه بالبراكتس مالتي أقبل ال 300. Okay. So withholding SCG if E2 high ما أنطي البريجنيل or SCG. I never trigger ovulation if more than 2 follicle or the serum E2 more than 300 picogram per deciliter. cancellation of the cycle أقولها عوفي هذا الشهر لا تحبلين. aspiration of oocyte after 36 hour SCG administration. يعني شنو؟ المريضة اجت أو أخذت SCG أو انطت بالخطأ SCG وهي عندها 3 فوليكل 4 فوليكل. So aspiration of oocyte after 36 hour SCG administration 36 ساعة أسوي لها aspiration under ultrasound guide. Albumin IV inhibit vasoactive material release from the ovary, intravenous albumin. calcium infusion 10 ml in 200 ml normal saline over 400 minutes 40 minutes. كبرغولين تاب 0.5 ملغ daily for 8 days اللي هو شنو الدوستينكس. من تجيني المريضة ovarian hyperstimulation syndrome أنطيها يومية حبة ليلا 8 أيام. ovarian hyperstimulation syndrome is a self-limiting disease وحده. but I want to give supportive measure. يعني مثلا اجتني المريضة moderate ovarian hyperstimulation syndrome require hospital admission، أدخلها إليك شو تسوي لها؟ encourage fluid intake. ليش قلنا اوليجيوريا decrease renal perfusion اوليجيوريا؟ اقلها شنو؟ شربي. اذا هي المريضه ما عندها نوزيا وفوميتنج اقلها حسبي لي اليورين اوتبوت. never use فوليس كاثيتر، لا حد يخلي لي كاثيتر. تجمع المريضه اليورين نير بيد، تخليه يعني ببطل بسطل باي شيء، بس ما تخلون فوليس كاثيتر. إذا المريضة عندها نوزيا أند فوميتنج شنو أنطيها؟ IV fluid to correct intravascular volume. IV fluid. never give Lasix لأن هي المريضة راح تجي إديمة، أسايتس، بريكارديال فيوجن، بلورال فيوجن. ما أنطي لازكس، أنطيها IV fluid to correct the intravascular volume. المريضة تصير ممكن هيمو concentration risk of thromboembolism and DIC. So I give what? anticoagulant in form of enoxaparin 6,000 international unit per day, or sometimes we give 4,000 international unit enoxaparin per day. Encourage movement. إذا عندها vomiting repeated vomiting ايش قلنا عندها يا المريضة؟ شيء هايبركاليميا عند اسيدوسيس. شنو راح يبقى عندها البوتاسيوم ويبقى عندها شنو؟ الهيدروجين due to renal effect of vascular endothelial growth factor تصير اسيدوسيس. انطيها انتي ايميتنج with normal saline وتجمع اليورين اوتبوت، وانطيها انوكسيبارين and observation chart. very rarely in severe ovarian hyperstimulation syndrome شنو نسوي لها؟ paracentesis. remove part of a fluid inside the abdomen under ultrasound guide, but avoid puncture of the cyst. Sometimes lead to hemorrhage. Hydroxyethyl start solution is a synthetic colloid 1000 ml of 600, significant decrease in ovarian hyperstimulation syndrome. Low dose aspirin 100 mg to decrease platelet hyperstimulation. قلنا hemo concentration from the first day of ovarian stimulation، يعني نعطيهم اسبرين 100 ملغ. vasopressin induce vascular endothelial growth factor secretion. Non-peptide vasopressin receptor is antagonist or inhibit the vascular endothelial growth factor. The treatment of ovarian hyperstimulation syndrome is symptomatic, conservative medical therapy for most patients، يعني مو surgical. المريضة من تجي ovarian hyperstimulation syndrome بعد يوم ينقسم منكم شنو؟ يصيرون جراحين قسم gynecologist and so on. So if patient receive ovulation induction and develop ovarian hyperstimulation, please never touch the patient, never touch the knife. medical therapy laparotomy only for torsion rupture internal bleeding. يعني إذا صارت شنو؟ rupture ovarian cyst, torsion ovarian cyst or massive internal bleeding، يعني internal bleeding مو ascites. Some patients require intensive care unit. Vaginal intercourse is restricted in all Grade 1s. The treatment for grade 1 supportive as need, fluid intake as thirst، يعني من تعطشين شربي. Grade 1 may develop into grade 2 or 3 if conception occur. Observation, enlargement of the abdomen, girth, weight gain, abdominal discomfort for 2 weeks or till menstrual bleeding. In grade 2, observation, bed rest, adequate fluid, ultrasound monitoring, serum electrolyte, BCV and creatinine. Resolution when the cyst is small into ultrasound symptom, decreased symptoms or resolution occur. Progression if the weight increase 2 pounds or more per day. Severity of symptom and according to severity of symptom. In cases of grade 3, maintaining blood volume, correcting fluid and electrolyte, relieve secondary complication like ascites and hydrothorax. If severe ascites lead to discomfort, shortness of breath, hydrothorax, pleural effusion, sometimes we need to what? Aspiration. Prevention of thromboembolic phenomena, as we speak, we give anticoagulant. We should maintain fluid balance. قلنا الأوفريان cyst أتابعها. We should maintain ovarian fluid balance due to shift of fluid from intravascular space to extravascular space to third space. Input, output, record, weight and girth. يعني شنو أقيس البطن مالتها بيش بمجرها إذا دخلت يمك. Measurement, BCV, CVB and tachycardia. 1 to 2 liter isotonic fluid in the first hour. Rapid future fluid, further fluid given with monitoring pulmonary wedge pressure. أول ما تجيني هي شنو dehydrated, repeated vomiting, shift of fluid from intravascular space to third space. So 1 to 2 liter isotonic fluid in the first hour. A plasma expander like dextran, human albumin 200 ml of 25 albumin over 4 hours. أنطيهم albumin. Plasma 500 to 1000 ml over 24 hours. أنطي plasma. Thromboembolism arterial 25%, venous 75%, lead to permanent neurological injury or even death. Hemoconcentration, hypercoagulation associated with increased estrogen. Prophylactic, low dose, low molecular weight, heparin, compression stocking, intermittent pneumatic compression. So this is the treatment of ovarian hyperstimulation syndrome. إيش قلنا أشياء لازم نحفظها هو شنو medical therapy. Never touch a knife unless what? Rupture, torsion or internal bleeding.